Did you know that your pancreas could become your worst enemy in just 48 hours? Today, we're diving deep into acute pancreatitis, the most common gastrointestinal emergency that every NEET PG aspirant needs to master.
And it's not just about memorizing facts. Understanding acute pancreatitis could literally be a matter of life and death for your future patients.
So let's start with the basics. What exactly defines acute pancreatitis?
Well, according to the revised Atlanta classification, you need 2 out of 3 criteria to diagnose acute pancreatitis: upper abdominal pain, elevated enzymes, or characteristic imaging findings.
And when you say elevated enzymes, how high are we talking?
Specifically, serum amylase or lipase levels need to be more than 3 times the upper limit of normal. This is a crucial point for the NEET PG exam.
Interesting. Now, what typically causes acute pancreatitis?
The 2 most common causes are gallstones and alcohol. But there's actually a clever mnemonic that NEET's PG students love: get smashed.
Get smashed? That sounds intriguing.
Yes, G for gallstones, E for ethanol, T for trauma, S for steroids, M for mumps, A for autoimmune, S for scorpion venom, H for hyperlipidemia, E for ERCP, and D for drugs.
Wait, did you say scorpion venom?
Yes, it's one of those rare but documented causes. But let's focus on what you're more likely to see in practice.
Right, let's talk about what actually happens in the pancreas during an acute attack.
The key event is abnormal activation of pancreatic enzymes within the pancreas itself. These enzymes, especially lipase, start digesting the surrounding fat.
That sounds painful.
It is. The fat gets converted to fatty acids and glycerol, which then combine with calcium to form these chalky white deposits, a process called saponification.
And that leads to hypocalcemia, right?
Exactly. This is a high-yield connection for the NEET PG exam. Saponification leading to hypocalcemia is a classic sequence they love to test.
Now, how do we classify the severity of acute pancreatitis?
According to the revised Atlanta classification, we have 3 categories: mild, moderately severe, and severe.
And what's the difference in mortality rates between these categories?
Here's where it gets interesting. Mild cases have less than 1% mortality, but severe cases can have up to 30% mortality.
That's quite a range. What determines whether a case becomes severe?
The key factor is organ failure. In severe cases, we see persistent organ failure lasting more than 48 hours.
And which organ typically fails first?
The initial sign of multi-organ dysfunction is usually impaired lung function, manifesting as ARDS, acute respiratory distress syndrome.
Let's talk about diagnosis. What imaging modalities do we use?
Interestingly, routine imaging isn't recommended for mild cases, but when needed, contrast-enhanced CT is the preferred choice.
Really? Why not image everyone?
Because studies have shown that CT doesn't change management or clinical outcomes in mild cases. It's only needed when there's diagnostic uncertainty.
What about treatment? What's the first step?
The cornerstone of treatment is aggressive fluid resuscitation. We're talking about 250-500 mmol per hour of isotonic crystalloid solution.
That's a lot of fluid.
Yes, and here's another high-yield point. Prophylactic antibiotics are not recommended unless there's confirmed infection.
What about feeding these patients?
Early feeding is actually encouraged. If oral feeding isn't tolerated, we use nasogastric or nasojejunal tubes rather than parenteral nutrition.
Speaking of medications, I heard something interesting about mesalazine.
Ah, yes. Mesalazine causes pancreatitis 7 times more frequently than sulfasalazine. That's another favorite NEET PG question.
Let's talk about complications. What should clinicians watch out for?
The 2 major killers are MODS within the first 2 weeks and sepsis after 2 weeks.
And what about long-term complications?
Some patients can develop pancreatic fluid collections or pseudocysts, which might require drainage if they become infected or symptomatic.
You mentioned gallstone pancreatitis earlier. How do we manage that specifically?
For mild gallstone pancreatitis, cholecystectomy is recommended during the initial admission. It has the best prognosis among all causes.
What about necrotizing pancreatitis? That sounds scary.
Actually, most cases can be managed medically. But if surgery is needed, minimally invasive approaches are preferred over open necrosectomy.
Are there any rare complications students should know about?
Yes, perture retinopathy. It's a rare but important complication that can cause temporary or permanent blindness.
How do we monitor disease progression?
CRP is now widely used as a severity marker. We also use various scoring systems like APACHE2 and BISAP.
Any recent developments in treatment?
Early trials of CM4620, a crack channel inhibitor, have shown promise, but supportive care remains the mainstay of treatment.
What's the most important thing for NEET PG students to remember?
Focus on the diagnostic criteria, severity classification, and the get smashed mnemonic. These are high-yield areas.
And what about clinical practice beyond the exam?
Remember that early recognition and aggressive fluid resuscitation can significantly improve outcomes.
Any final pearls of wisdom?
Yes, don't underestimate mild cases, but don't overtreat them either. Each case needs individualized management.
Speaking of which, did you know the word pancreas comes from Greek, meaning all flesh?
That's fascinating, and quite fitting, given how this organ can affect the entire body when inflamed.
Well, that brings us to the end of today's episode. Any last thoughts?
Remember, acute pancreatitis is a dynamic condition. Your management strategy should be just as dynamic.
Thank you for joining us on Copilot Podcasts. Next time you see elevated pancreatic enzymes, you'll know exactly what to do.